Sorry for that interruption. Okay, so we ended on the pathophysiology of emphysema. We are continuing in part 2. However, we are saying the alveoli and the small distal airways are primarily affected by the disease, followed by the effects in the larger airways. Elastic recoil is usually responsible for splinting of the bronchioles open, which we have already established. However, with emphysema, the bronchioles lose their stabilizing function and therefore causing a collapse in the airways, resulting in gas to be trapped distal. There is an erosion of alveolar septa, so the septa, the walls in between start eroding, causing there to be an enlargement in the available airspace in the alveoli, in which there is sometimes a formation of what is known as a building with their thin walls. So what happens is when this alveoli starts, the septa starts breaking. When it breaks, it will connect with the other alveoli, and together they will give in and they form a balloon type, a balloon like, which is referred to as a building. Okay. Smoking contributes to the development of this condition by activating the inflammatory process. The inhaled irritants cause inflammatory cells to be released from the polymorphonuclear leukocytes and the alveolar macrophages to move into the lungs. The inflammatory cells are known as the proteolytic enzymes, which the lungs are usually protected against due to the action of all the antiproteases, such as the alpha-1 antitrypsin. However, the irritants from smoking will have an effect on the alpha-1 antitrypsin, reducing its activity. So this actually suggests that this alpha-1 antitrypsin, we actually normally have it. Okay, we normally have it and it protects us from the harmful effects from the harmful substances that are produced around and the whatever comes about. It usually protects us. But in the in an event that there is an active inflammation that is taking place, these usually they are weakened. Their responses are weakened. In that the irritants from smoking will have an effect on this alpha-1 antitrypsin, reducing its activity. Therefore, emphysema develops in this situation when the production and the activity of the antiprotease are not sufficient to counter the harmful effects of excess protease production. A result of this is the destruction of the alveolar walls and the breakdown of elastic tissue as well as collagen. The loss of alveolar tissue leads to a reduction of the surface area for gaseous exchange, which increases the rate of blood flow through the pulmonary capillary system. Okay, so this is just a pictorial view of what we expect from smoking, from the nicotine, which is the active substance in smoking, goes into the airway, inflammatory mediators, reactive oxygen species are released, and inflammatory mediators will go there and cause the effects, on the action of the neutrophils, which will now go on to work on the tissues and cause the heightened response on the macrophage response and cause all the effects that we are talking about, ending with damaging the tissues, which will actually erode their elasticity. So this is what happens in emphysema. And at the end of the day, once the tissue have been eaten up, then the emphysema is going to, then the diagnosis will be emphysema. So this can result from the social activity of smoking into this pathology, or it can result from the congenital abnormality In the deficiency of alpha-1 antitrypsin, it will still cause the neutrophic, the same reaction, which will lead to tissue damage and lead to emphysema. Okay. The next condition we are talking about in COPD is asthma, which is one of the common conditions. Asthma is a relatively common condition that is characterized by at least partially reversible inflammation of the airways and the reversible airway obstruction due to airway hyperactivity. It can be acute, subacute, chronic, or exercise-induced. It is a major non-communicable disease affecting both children and adults, affecting an estimated 262 million people in 2019 and caused 400, okay, 400,000 461 deaths. It is the most common chronic disease among children. Inhaled medication can be controlled. So what happens is when you're suspecting asthma, you give inhaled medication and see how the response is going to be. Avoiding asthma, if the response is positive, then you can diagnose asthma. If not, then you can try other means. Avoiding asthma triggers can also help to reduce asthma symptoms. People that have asthma, people that have asthma, usually they know what triggers the attack, and avoiding it is actually the best. Most asthma-related deaths occur in low and lower middle income countries where underdiagnosis and undertreatment is a challenge. Inflammation, in the etiology, inflammation plays a major role in asthma and involves multiple cell types and mediators. The factors that initiate the inflammatory processes are complex and still under investigations. Among them, we have the genetic factors, e.g. the cytokine response and the environmental factors such as the allergen, the pollution, and the microbes. At a crucial time in the development of the immune system are known to be involved. So at least one of these pointers, or they actually they have actually been found or implicated, they have been implicated in the pathogenesis of asthma. So this is how the normal airway will look like. Then in asthma, which is due to spasmodic contractions, this is how the airway will look like. To have narrowed airway, which is limited, filled with mucus. So apart from narrowing and the tissue that is inflamed, this tissue gets inflamed, the lumen gets inflamed, then spasmodic contractions constrict the airway, reducing the lumen. Then because of the inflammation, the goblet cells are going to produce more mucus, thereby narrowing the airway even further. So this is what happens in asthma, and this is what is supposed to be normal. So you can see the difference there. Risk factors. Asthma is more likely if other family members also have asthma, particularly a close relative such as a parent or sibling. Asthma is more likely in people who have other allergic conditions such as eczema, rhinitis, and all those other conditions. It is also associated with urbanization, with increased asthma prevalence, probably due to multiple lifestyle factors. Events in early life affect the development of the lungs and can increase the risk of asthma, e.g., low birth weight, prematurity, exposure to tobacco, as well as other sources of pollution. So it gives you an idea in which people it is usually prevalent. Exposure to a range of environmental allergens and irritants are also thought to increase the risk of asthma, e.g., indoor or outdoor air pollution, house dust, mites, and all those occupational exposures, fumes, and dust that predisposes people to developing this condition. Children and adults who are overweight or obese are at a greater risk of developing asthma. So it can be either genetic, environmental, and one of those at least has been implicated in the causative agents of asthma. It is a condition of acute fully reversible airway inflammation. Fully reversible, mark that word, often following exposure to an environmental trigger. It is reversible, and that is the reason why people use those cans to reverse the attack. Okay, the pathological process begins with the inhalation of an irritant, which could either be cold air or an allergen, which then, due to bronchial hypersensitivity, leads to airway inflammation and an increase in mucus production. This leads to a significant increase in the airway resistance, which is most pronounced on expiration. Air obstruction occurs due to a combination of factors such as inflammatory cells infiltration, mucus hypersecretion, smooth muscle contraction, and these reversible changes may become irreversible over time due to basement membrane thickening, collagen disposition, as well as airway remodeling in chronic disease. So meaning, due to these acute attacks, if it is not controlled on time, it becomes chronic, and when it becomes chronic, it becomes some kind of there is some kind of normal texture, and it becomes a life-challenging, a life-threatening situation. If not corrected rapidly, asthma may become more difficult to treat, as the mucus production prevents the inhaled medication from actually reaching the mucosa. We already saw in that picture how the mucus will be produced and on an inflamed structure. So that plenty mucus that will be produced due to inflammation can actually stop the medication from reaching the lumen, thereby becoming irreversible. This process is resolved, okay, with beta-2 agonists, which are salbutamol, the inhalers. Actually, they are called the inhalers. So this can be treated by the inhalers, which were salbutamol, salmeterol, or albuterol, and can be aided by muscarinic receptors antagonists, okay, which act to reduce the inflammation and relax the bronchial musculature, as well as reducing mucus production. So you find a person who has asthma, immediately they get into an attack, they just get an inhaler and do a bit of a small a little number of shots, and it goes into the lumen and reverses all this. So this is what the normal will be. This is the pictorial view of the lumen, the normal lumen, the asthmatic lumen. When it has become chronic, okay, it is already there, it is chronic, it will be like that, with a lot of mucus production inside, with already kind of constricted lumen. When there is an attack, actually it even becomes worse, and the lumen structures start becoming, start tightening, start constricting, thereby trapping air in the distal end, and it becomes that bad. So that is about asthma, which is one of the COPDs. The other COPD is bronchiectasis, which is a chronic lung disease identified by persistent and lifelong widening of the bronchial airways and weakening of the function of the mucociliary transport mechanism due to repeated infection. These airway changes allow for easier bacterial invasion and extra mucus pooling in the widened airways, making them prone to infection. So once this mucus plugs in, it stays, okay, because it cannot be cleared in good time because of the mucociliary function that has been affected. So this mucus stasis is going to give a very good breathing environment for infection. And once infection sets in there, starts multiplying, it is referred to as a bronchiectasis. The condition is characterized by a persistent cough with excessive amount of mucus and frequent airflow obstruction, together with episodes of worsening symptoms. Okay, the acute cause of bronchiectasis is not known. The cause of bronchiectasis is not known. Some conditions known to cause bronchiectasis that affect or damage airways are conditions that damage the airways, raising the risk of lung infection. For example, in allergic bronchopulmonary aspergillosis, in pneumonia, measles, inherited, those conditions can lead to a condition that is referred to as bronchiectasis. Immunodeficiency predisposes the person to lung infection, which will lead to a presentation of bronchiectasis. Pulmonary disease, part of the COPDs, including asthma, amongst others, including just lung infection, which could be due to TB and airway blockage. So, bronchiectasis, in other words, is just a condition that will result due to uh, due to failure to clear the airway, resulting in infection. That infection is going to start reducing producing the proteolytic enzymes that are going to start denaturing the integrity of the underlying tissue, thereby making it kind of inelastic and bringing about this infection as well as the blockage, which is referred to as a bronchiectasis. So bronchiectasis, as you have seen, it can arise from a number of, a variety, actually, wide variety of diseases. It can be due to lung infection itself, direct lung infection, or secondary to other diseases that will bring about the same problem. Bronchiectasis predominance is not clearly understood. The incidence of bronchiectasis has risen over the past few years. It can exist in any age group, but it generally occurs, okay, in childhood during the pre-antibiotic period. New evidence shows that bronchiectasis disproportionately affects women and other individuals. The three most significant mechanisms that contribute to the pathogenesis of bronchiectasis are recurrent infection, air obstruction, and the peribronchial fibrosis. The process begins with inflammation, damage to the bronchial walls, which then stimulate the formation of excess thick mucus. The thick mucus splashes the cilia and causes further damage. The immune response releases toxic inflammatory chemicals, such as that which is released by the neutrophils, as well as leads to fibrosis and bronchospasms if persistent. The next one in line is cystic fibrosis. Cystic fibrosis is an inherited disorder that can lead to a variety of clinical manifestations. Okay, it is an inherited, it is genetic. In an attempt to better understand the pathology of this disorder, it is important to analyze the specific anatomical structures that will be impacted by this disease process. So this is why this condition affects a wide range of, a variety of organs. It can affect the sinuses, okay? It can affect the lungs, the skin, the liver, the pancreas, the intestine, as well as the reproductive organs. So it does not only affect the respiratory system. If it affects the respiratory system, it will bring about some obstruction in that it is going to cause inflammation. Whenever there is inflammation, there is a production of increased production of mucus. Once there is increased production of mucus, cilia will not manage to work accordingly, it will not manage to sweep off the accumulants, hence it is going to clog. And once they clog, then they bring up all sorts of problems that fall under respiratory disorder. So it can cause obstruction in all these other organs that I explained here, as well as in the reproductive system. In the musculoskeletal system, inspiratory muscle atrophy will result, as well as atrophy in anti-gravity muscles such as the gastrocnemius, as well as kyphosis. So these are the effects which cystic fibrosis is going to have. Okay. So this is just illustrating on what will really happen in cystic fibrosis and what effects it is going to have in other organs. So This was an overview on COPDs. Let us see to it that we actually read on each one of them and each one of the individual topics that have been discussed. Was just giving an overview so that you have an idea of what you should be looking at when looking at the when actually reading on each of the specific conditions. Thank you so much. Thank you for listening.